So thank you, Jennifer. Thank you, Abu. Thank you to Stanford for hosting this. This is a great venue. It's a great event. It's acknowledging the hard work that so many of you have done to stay healthy, to find answers, and to advance your life after SCAD. And I know that there's many family members here as well. And any illness, but particularly heart disease and particularly SCAD, affects the whole family. So it's so important that you're all here together, because even if you're not here with a loved one, I know that your loved ones have really been on this journey with you. So I was asked to talk a little bit about where we've come. And I'm gonna, during this talk, skip a little bit back and forth where we've come. Well, I came from this, actually, yesterday. For those of you who have been to Minnesota, I mean, seriously, we do get spring snows, but, and I didn't take this picture right before I came, but usually they go away, and you're having rain, we're having record low temperatures in Minnesota. This is nicer. So where we've come, this was what is believed to be the first reported case. You can see the date is 1931 of SCAD. There's some, was it the aorta or was it the coronary? But this is what Dr. Preddy had presented. And then there was this drought of information about this condition. I think all of the cardiologists in this room, we learned the same thing when we were in our training. It was something we'd virtually never see. We were told what to look for in an angiogram, which we know was not all of SCAD. And so we moved forward. Yes. And these were custom M&Ms that were made for the 60th birthday of a SCAD survivor, and I could not resist taking a picture of them. So if we flash back to 2009, which is really when I started looking at this in a different way than I had. I founded a women's heart clinic in 1998 at Mayo Clinic, so it's 20 years this year. But even in 2009, I was still thinking that SCAD was pretty much the same thing that I had been told and taught in cardiology school. So patients who had SCAD before 2009, and then for a few years after, until some of the folks in this room started publishing and getting the word out, they basically stopped with their Google search, because most were autopsy series. So they figured, I don't want to go there. I don't want to read about a bunch of dead people. The fatality rate that was being touted as up to 80%, and it was described as incredibly rare. So you can imagine, and some of you don't have to imagine, you were among those people, you thought you were this oddity that you were lucky to be alive and you didn't think about it anymore. Also, the demographics were about 70% women at that time. Basically, since then, we feel like it's much more a 90% or above, and that the majority that were being reported were peripartum, like 2/3 of them, which we also will talk about. So flash forward to last month. So my son lives down in the Mission District. He works for a nonprofit called Compass, and he sent me this cryptic email, as 22-year-old sons send to their mother, know her, and he had forwarded me an email from somebody who worked in his company. This was sent out during National SCAD Heart Attack Awareness Week. For those of you who don't know me, I'm a program director. Just 5 days before my 42nd birthday, I had a heart attack. She goes on to say, it's Heart Attack Month. I feel compelled to tell her. So this is my son, who really hadn't paid much attention to what his mother had been doing. And of course, I did not know her, but I replied to my son, she might know who I am. So if you wanted, and he has the same last name, you might want to let her know. So he did. And then literally the next day, a nanny who had cared for him, who's about 40 years old, had been diagnosed with SCAD. So my son sent me an email, 10 years ago, no one knew they had SCAD. Now everyone has SCAD. His word. And I would say that perhaps knowing Sharon Hayes is a risk factor for having SCAD. So since 2009, what has changed? Well, a lot. Still need a lot more knowledge, and I'm going to make that point, as will virtually every other speaker today. We are still really at the beginning, but we're so much farther than we were. So first of all, and we're going to spend some time on this, it's because of people like you. Patient advocacy, advocating for yourself, advocating for others, advocating for knowledge, making your doctors and the researchers do what they should do about this and not accept we don't know. The collaboration. So when we first started this, we didn't know that Jackie Saw was working at the same time on this topic. And now we are talking to each other, and the fruits will only accelerate the kinds of things that we know. So there's larger case series. The largest case series was 42 patients when I went back and looked. And now we've got case series with hundreds of patients and registries with close to 1,000 patients. We still face a real dissemination gap. So as much as knowledge we've gained, and we'll talk about what we know now, it hasn't really gotten down to the level of the community hospital cardiologist or the emergency room doctor or the private practice cardiologist. And those are the kinds of things that are sort of that next step. And we are committed, I will tell you that everyone in this room is committed to driving for those answers and the dissemination. So I wanted to tell you a story, and I can tell it because this individual just told her story for WebMD.com, and so, but it is why we still have to focus on this. Because for women with SCAD, in particular, there is a double whammy. First of all, we don't know much about SCAD, but we've got the same problem we had 20, 25 years ago, is that women sometimes are not taken seriously with their symptoms or assumed to have a heart attack, particularly somebody who doesn't look like a heart attack patient. So this was a patient who was sitting in my office, and she was sitting with her sister, and her sister had told me she had had SCAD and she'd been treated very appropriately in an urban medical center. So this woman, 10 days after her sister had SCAD, started having chest pain. She had a few risk factors. She was a very anxious person, and I say that that's important because I am sure she was very anxious. Who wouldn't be when they are having a heart attack? She was a runner. She told the doctors, my sister had a heart attack 10 days ago. It was called SCAD. Do you think this could be it? And I think that actually made it worse because they said, oh, you're just thinking you're having a Me Too heart attack. Her troponin was elevated, but despite that, she was dismissed and told she had gastric reflux and anxiety. They scheduled her an outpatient stress test, which was negative. She continued to have symptoms, and she went back to another doctor who gave her gabapentin, which is Lyrica, which is something for chronic pain. She continued to be really unwell, and her family said, you gotta go see your internist. So her internist rechecked the troponin, and now it was even higher. So he did an ECG, which showed actually ST elevation, and she had, which is the most serious type of heart attack. She had some wall motion abnormalities on an echocardiogram, which also means the heart's not getting enough blood. And they then again called it myocarditis, and she had a cath the next day. By the time, this is day 6 of having a heart attack at home, she had reduced heart pumping function and an occluded vessel. And this was a quote from the WebMD article. There's no way that if I was a man and I'd come in with those symptoms, I'd have been turned away and told I just have anxiety. If I was a man, I would have been taken seriously. So this is not about women, but it is that double bind that I think for SCAD survivors affects not being taken seriously. And this was a study that really informed me. So this was a study where they took a bunch of doctors who looked at videos of somebody describing some potentially cardiac symptoms. And they had an actress, and in one of the readings, so it's a transcript, in one of the ways she acted like she was in a business suit, and she talked just like I'm talking to you. And she also did it what they called histrionic. She had big hair, big nails, and she just emoted, but same words. And then they had another group of doctors read a transcript. So you can imagine that the gradient of people who thought the business life, they took her seriously. Functional for doctors means it's all in her head, so most thought when she was being histrionic. And referred for cardiac evaluation, the businesswoman perhaps got more. So I think the point is that I take away and share with a lot of my colleagues is we should not expect patients to present their symptoms in a way that is acceptable to we physicians and we healthcare providers, that we need to work on that. So these are some of the things that are at baseline for SCAD patients. So we've talked about how SCAD is different. It must be evaluated and researched differently. Many of you know this, but I want to make sure that we're level set. So SCAD takes a normal artery that doesn't have any plaque in it, and there's a split. And you either get a flap, like in that second one, or you get a little bruise within layers, so there's bleeding within 2 layers of the artery. and you don't see a flap. It's that flap on the angiogram that we were taught back in cardiology school that we should be looking for. But now we know that it actually is that third one down that is the most common way that it comes. You can imagine, so you see that atherosclerosis or the plaque type blockage on the bottom one, and you can see if we're taking only an angiogram that the two bottom ones could look exactly alike because we're not seeing the layers. You just see that blockage. So we flash forward to where we are now, and I think we're all still giddy and excited that, and there's several of the co-authors, that we finally have this American Heart Association scientific statement that puts out really the world's experts on all aspects of SCAD. Not that we have all the answers, but that we at least can talk about the topics and put out there what we don't know. So I'd encourage you, download this, take it to your doctors if they don't know. If they haven't, you probably already have. Because, and so from that, we've had lots of scientific presentations, including a whole session on SCAD at last month's American College of Cardiology meeting. And you see Dr. Sears Edwards, who's at the podium there speaking. It's making the news. You saw WebMD, got the Today Show, Dr. Oz, WebMD magazine in the print magazine. We've got national news. We've got Women's Day magazine. SCAD's out there, finally. So what you see here is you see some experts there. You see some people who are coming together. You see some advocacy. You see Catherine Leon standing there with Dr. Oz, and I'll talk about her story because she's here in the audience and we'll speak later. But SCAD patients, just like you are today, are coming together and making a difference. You are e-patients, equipped, enabled, empowered, and engaged. And that's what's going to take this, because we doctors can do a lot, the research can do a lot, but having patients engaged has been the reason that we've made progress so fast. So I'm going to take you back to the start of my story of SCAD. So I have been a part of the Scientific Advisory Council. I served on the board of directors for an organization called Women Heart, which is the National Coalition for Women with Heart Disease. It serves women with all types of heart disease. It trains women who have heart disease to go out and be advocates and educators for other women. And we've run a program to do that at Mayo Clinic since 2002. Every fall, about 60 women come in and they learn about heart disease and how to teach others. So in 2009, often the night before at the opening dinner, people say why they're there. And some people reveal their diagnoses, some talk about other things of why they're there. But I remember like 3 out of 60 said I had a coronary dissection. And I remember thinking, that sounds like a lot, but not thinking much of it. And then a coffee break during the meeting, Catherine Leon came up to me and she said, Dr. Hayes, what is Mayo Clinic doing about SCAD research? And I sort of puffed up and I said, well, we couldn't possibly research it because it's so rare that you could never get enough people to actually do the research. And she let me go on. And then she said, well, what would you say if there's like at least 70 women on the Women Heart online community? So an organization that I was already very much part of, that are SCAD, and they're from all over, and we've developed a research agenda. I said, oh. So I went back, these are long days, I'm the course director. I went back to my office, I did a PubMed search, and found that on the largest case series was 42. So this was the follow-up email that she sent. As of today, 86 user IDs represent women on the Women Heart website. The material is segmented by cause unknown and postpartum. Each category is arranged by age, so she sent me this list. These were some of the research questions that back in 2009, this group of 80 patients or so, and I think it's important to look at that because they remain important research questions today. Well, let's just look at those. The overriding concerns are whether we'll suffer another SCAD. 2 women in the data claim they have. I thought that was interesting. And will we pass this on to our students? And I think, our children, and this was if this small universe from the online community provides a starting point, maybe a mechanism could be set up for cardiologists nationwide to report SCAD for inclusion in ongoing research. So if nothing else, that has happened. But there remain some challenges for actually accessing this population. So remember, this is like a social media community. They have screen names. We don't have emails. We don't have where they are. We don't have their real names even. This was what we started with. I knew a few of them. So we spent some time thinking about how would we even get at this if we were going to do this, because, and so we came up with a little protocol. It was really a beta test. We got an IRB approval for 12 patients. We'll just see if we can do some questionnaires, we can get their angiograms and confirm the diagnosis and just see if we could do it and then take it out there. I worked with my colleague, Dr. Marisha Tweet. At the time, she was an internal medicine resident, a remarkable woman then and now, and is committed basically her whole career to studying SCAD. But this was our first little poster. So we just reported on those 12 patients. You can't really make much out of what SCAD is or was out of 12 patients, but we did prove that we could actually do this. The hardest thing was getting the angiograms to get them to Mayo Clinic for somebody to review. And part of that was some for Australia and England and other places because we didn't actually know where these people were from when we accepted them into this first 12. So we tried to publish it, and it was actually kind of challenging to publish it because obviously 12 patients wasn't the largest series. We weren't gonna, so we actually, after a revision, we asked one of our head of social media to be one of the co-authors, Lee Acey, who helped us frame this in a way that, no, this isn't about SCAD, this is about a method of research. We published it, and I'd also pitched it to a science writer at the Wall Street Journal, and he was very interested. He thought this was a really cool story about patient activism and self-advocacy. So he did a story at the same time. And that was really pivotal because it highlighted the work, it highlighted the condition, and it highlighted, and Wall Street Journal goes to a lot of places, including overseas. So what was the fallout of that? And we were ready. We were ready to expand the research and enroll people if they saw this. So these are some quotes from folks who wrote in about the Wall Street Journal report. Ron Winslow, who is the author, this is right after he wrote it. He says this is one of the most impactful articles he's ever written. I just heard from an ER doc in DC who had heard of SCAD but hadn't seen a case in 9 years until the day the story came out. That day he saw a patient with chest pain 2 years after the SCAD diagnosis. Now she and her doc have been in touch with Mayo about the study. I'm a family physician, I had SCAD. I saw the Wall Street Journal article, ironically, the day I began cardiac rehab. My favorite one is that last one, subject line, recently diagnosed with SCAD, US citizen in Shanghai, China. Mm-hmm. You have to open that one, right? Mm-hmm. So it was a woman who was in the hospital. Over in China, they keep them in the hospital for 2 or 3 weeks after, and they believe that cardiac rehab isn't very safe. So she was sitting there in the hospital, but her doctor had trained in the US and had brought the Wall Street Journal and something else. So it really got out there. And that was really important. So, just as an update, we now hit over 900 patients from that original 12. And what we do is we get their imaging, their angiogram, we make sure that it actually is a diagnosis of SCAD, send out a bunch of questionnaires. We ask people to write a personal SCAD narrative. Most research studies are done on people who actually are in one's office. And you get to ask them a lot of questions. I get to ask them, how did it feel? What was this train of events? This allows patients to tell their story. And then that has led to a bigger clinical practice as well. It's also led to the way we in medicine communicate our findings to other folks to change practice. So you saw flipping through a lot of publications that have happened back since that first one, including the one we think is really important that we all worked on. And that's that next step. But another reason this is important is the AHA scientific statement is, it's wonderful if any of these smart doctors, including me, publish a paper, but that's just one center or one group, and so people don't immediately embrace a single study, and that's appropriate. You want to wait until you've got a consensus, and that's one thing that this did. So where are we? Well, we defined SCAD, we've already done that, but it's important that part of the reason for those different statistics early on is they were including people who had had damage to their artery from another cause, or damage to an artery, a dissection that happened because they had a plaque that ruptured. So that's not really what we're talking about. So what we know now, it's not atherosclerosis. And it acts completely differently. But the problem was, a decade ago, people were being either not diagnosed or they were being treated as if they had atherosclerosis. It's actually more disproportionately women and far less of the peripartum group. And I think part of it is the only ones they were recognizing prior to 2009 were the ones that happened in pregnant women, because that was, everyone said that's a risk factor time. So it's not that fewer pregnant women or peripartum women are having SCAD, it's that we're recognizing more of the non-peripartum ones. The other big thing we know is it is not rare. It isn't something that, like I was taught, I'll see only a few. Now, I realize I'm a biased sample. I see a whole lot more than the average cardiologist, but even cardiologists now, because they see it, it's a pattern recognition, they are recognizing, oh, could this be SCAD? That's very gratifying when you see that in the initial history and physical on an admitted patient, that you say, the differential diagnosis, that's when you're thinking all the things, I think this patient might have SCAD. We also have different tools to diagnose it, which has helped. So this particular is, and I'll just let it run, the circle in the middle, that's a catheter. It's called an OCT catheter. And you see the dark spot, that's the artery where the blood would be going. And you can see it's very compressed, and sometimes very, very compressed, because on the outside there's a bleed within the artery wall, this intramural hematoma. So the fact that we have this technique and intravascular ultrasound has helped convince cardiologists that this is a thing that is affecting and causing heart attacks. Now, we don't hardly have to use this anymore, except in cases in which we're not sure, because once we kind of know what we're looking at, we don't need to do this. And this does add, and just for those of us, this is done at the time of an angiogram. This is a catheter that goes down into the artery, so it does have some risk in that it could further damage the artery. We also know that some patients were told, oh, you're lucky to be alive because there's an 80% fatality rate, and other patients were told back then, oh, this is a fluke, it'll never happen again. And so we now know somewhat better that it's not benign, that a lot of patients present with or come into the hospital with the most serious type of heart attack called a STEMI, ST elevation MI, some with cardiac arrest, and about a quarter who actually first come in with multiple vessels affected. The recurrence rate, although this one's a tough one, it's an important issue for you SCAD survivors, but the data sets that we have right now are biased in the sense that we don't include everyone. But when we came up with about a 2% per year recurrence rate, we thought that seemed high, but Dr. Saw has similarly had very similar, and so what we have to tell patients is this can recur, so pay attention to the symptoms, but I would argue you live your life as if it's not gonna happen, because there's not another way to do it. The other important thing is that traditional heart attack treatments, such as going in and opening up that artery immediately, which is what our guidelines told us to do in a STEMI, actually were far less successful and had the potential to cause harm in SCAD patients. There are different associated risk factors. We know the pregnancy, FMD, arterial tortuosity, and others, and that these often heal without treatment. So you can see here, I'm not sure with the light if you can see it pretty well, but you see at the baseline, that's a SCAD in that artery, and then 4 months later, it's wide open. And that's not because anybody went in and did an angioplasty or did anything special, it healed on its own. And that's really common. And as Dr. Saw has found, maybe 90% healed in a month or so. The other thing that's gratifying, so this is my colleague, Dr. Tweet. She was presenting on at a meeting, and these two young moderators standing to her right, I loved it. I was sitting in the audience, and they asked her, well, of course, it's well known, it's established practice that, now this is 18 months ago, it's established practice that one wouldn't go in immediately and do a stenting of a SCAD patient. Well, she was first author on one of the studies that actually did that, so I was kind of interested in how she was going to respond. But what I really was happy is, here these people, it had been completely incorporated into their practice, so at least in their young age, they felt like this was the way to treat SCAD patients. So that is the good news. And so there is some information about that in the AHA scientific statement. And really what making the point is if patients are stable, their artery has decent flow, and they don't have high-risk features, meaning it's multiple vessels involved, then a watchful waiting approach is probably best for SCAD patients. And that's very different than how we treated them previously. The other part is the associated conditions. These, certainly the biggest news, and you've got some fibromuscular dysplasia or FMD experts right here in the room for you, is the association of FMD and SCAD. So we sort of think about this is a vulnerable patient who has a condition, or it may be permanent, like an FMD, or transient, like a hormonal flux, and then a trigger that may lead to SCAD. And that's what's so tough, because this isn't like atherosclerosis where you've had a buildup over decades of something that just is waiting to happen. So this is an image of fibromuscular dysplasia. The way we looked at it is half of the patients who had a femoral angiogram as part of their initial coronary angiogram, and that's something that interventionalists do when they go in, they make sure that their catheter's in the right place, had this lumpy, bumpy changes of their femoral artery. So when we started doing CTs, we could see the same thing. Dr. Saw came at it from a completely different way, which was great because we knew that it was a real thing, a real association. Migraine headaches appear to be more prevalent in SCAD patients. We've known for a while that they are more prevalent in FMD patients. So tortuosity, that's kind of a medical word. When I talk about Lombard Street, which you guys all know, or other things, that's what we mean. And when coronary arteries, we noticed that coronary arteries in SCAD patients were more tortuous. And so you can see the little cartoon there. And we actually looked at that. One of our fellows now on faculty at Mayo actually did this painstaking artery, oh gosh, I'm glad he did it. But he found that among SCAD patients, about 70% of them had coronary tortuosity versus about 30% of normal people. I think the other important thing, and we're going to hear a lot about this, is the effect on the psyche of having a heart attack when you're 20 or 30 or 40 or 50 or 60. It doesn't matter the age. We know that there is a significant effect on the psyche, male or female. But we also know that it's sort of a double risk factor because women under the age of 60 who have a heart attack, SCAD or not, are at the highest risk for developing depression after that heart attack. So if you think about who are the bulk of the patients who are having SCADs, they already are at a higher risk. And then you add to the fact that you've got this condition for which we have so few answers, it just adds to the anxiety. So I think that's an important part and is a part of the report. And this was one area, so my daughter's getting her PhD in clinical psych in May, and she actually was first author on this particular study because we need psychology support at the time. So it was the one time, and her name's different, so there won't be two Hayes on any future work. To get married. I think the other issue that we understand better is that now compared to previously is chest pain after SCAD is incredibly common, far more common than patients who have atherosclerotic heart attacks. We don't completely understand why that is, but we certainly know that it is much more common, and up to 50% will have that. Some of it's high body awareness and non-cardiac pain, and some is a complication of the SCAD, and some is something kind of different than what we see, where patients have chest pain that's relieved with nitroglycerin, but not necessarily caused when they walk up the steps with exertion. And so that was one thing that we felt with this, with the statement, that we wanted to address that particular thing that's a bit different. And we don't have all the answers, but it's important to acknowledge and for doctors to not poo-poo this, nor to do an angiogram in every patient who presents with a little chest pain too. The pregnancy issue, one of the other things that I was asked by some of the patient advocates really early on was, please, please, please educate the OB-GYNs, because they're blowing off women who are having heart attacks after having babies. They're not aware of what needs to happen. People are coming in with symptoms after they have a child and being sent home and said, oh, you got a lot of fluids during pregnancy, that's probably why you're short of breath. during your delivery. So this was one of our goals, and so getting it out to other healthcare providers. And then, again, harking back to that initial letter saying we're really concerned about our kids and what are some of the genetic factors. You're going to have a whole talk on genetics, but I think that it's important to know that we've been paying attention collectively to this. What we would observe is that actual familial SCAD is very, very uncommon. So SCAD's uncommon. Having people in the family member have familial SCAD is very, very uncommon. Familial FMD also happens, but it's very, very uncommon compared to. So out of our over 900 patients, only 8 families are familial, so 16, 17 of them. This was a case that we looked at, and individuals were some case reports for the first 5 of them. And so we actually did do whole exome sequencing on a group of patients, some of which were familial, some of which were sporadic. And I think the short answer is there isn't a SCAD gene. That would have been the great thing, to know that there was a single gene that we could test for. The study did yield what we call candidate genes, and those candidate genes mean that they were present in the family members, and they were present in the SCAD patient, and they were expressed in vascular tissue, so could have had something to do with SCAD, but they were different genes for each family. So there was not a single thing. So I wanted to give you just an update. These are from my colleague, Dr. Tim Olson, who is the principal investigator on the genetic side of our research. So anybody who's accepted into that registry is also offered an opportunity to give some DNA, and if their parents are alive, their parents can give a cheek swab as well. So we're up to over 700 participants in the US and another scattering internationally. So what we've got is, because we do a deep dive into what's going on in these patients, Dr. Olson's team has the genetics plus all of the information. We kind of call it a deep phenotyping. And so of those who are enrolled in the main study, over 83% of patients have chosen to give their DNA, which is great. So we have 450 parents, and then the parent trios. Those are kind of that richest when you get mom, dad, and the patient, and 8 SCAD families. And I think, just so you think why this isn't simple, and I'm sure that our genetics talk will talk about that, we know that there are some conditions like Marfan syndrome, where there is a single gene, we can test for it, it's inherited dominantly or recessively, but we can track it. And then there's other conditions that are multi-gene, like atherosclerosis. There isn't a gene for people who get plaque, but there are a lot of genes that contribute to risk. And so where is SCAD in all of this? And I think that's been, where on that spectrum is the kinds of questions that we're looking at. So looking at whole exome sequencing, that's what we did and found there wasn't a particular gene. And then genome-wide association studies, which is looking for common genetic things that might speak to a risk. So those are the steps that are happening now. We don't really have answers for you, but I think it's important to know that participation in research providing DNA can help us as scientists advance this field. So there's a bunch of people that we want to thank or who are involved, and I think not because you want to know who these people are, but I think it's important to know that there are radiologists, there are OB-GYNs, many of our trainees are now involved in this. We've got interventional cardiologists, we've got geneticists, and data people. I also, in the process of thanking, I really want to acknowledge SCAD Research, Inc. SCAD Research, Inc. was a nonprofit that was founded by a man whose wife died of SCAD, Bob Alico. And when he met with me, he started the whole thing because he wanted to do research on SCAD, because he was told that by doctors that they don't know why Judy died. And so from an initial small gift, they have turned out to be one of our major supporters for our research, which we very much appreciate. And if any of you are interested in meeting other SCAD survivors, participating in one of the many skedaddles that get SCAD folks, there is one in Carlsbad, California, as well as one next weekend in Florida, if you want to get out of the if you want to get some other sun. So I think that as we move forward, the research that has gotten us this far needs to continue from everyone in this room. And so as we move forward, and those are some of the folks, that's actually Bob standing with at the top in the middle, standing with my colleague Rajiv Gulati. The Mayo folks are all behind looking at SCAD. These are all some of our geneticists and our study coordinators, and that's Dr. Tweet with her arm raised in victory because actually that was the time when she had 3 kids and she was really pretty far behind because she had 2 in strollers and the toddler was walking. But so I think that was her way of saying, yeah, I made it across the finish line, actually. So I want to thank all of you who are in this room who are here today and are moving forward with your lives, with participation in research, with your education, with educating your doctors, which you should not have to do. But we know that that unfortunately is still a big issue. But we hope that some of the things that you take away from all of our speakers today are going to help you in that regard. So thank you very much.